Hi, welcome, welcome. Thank you all so much for joining us. Yep, we're still letting some folks in, so get comfortable because we're going to be here for the next hour and a half to hear amazing presentations from our speakers. So welcome, welcome. And you all should be able to access the chat during this webinar. So again, feel free to utilize the chat. So I think we're just going to give it another minute to let some folks join online. And then we're going to kick it off with Mike Royster. I love it already. The chat is blowing up. That's great. Definitely feel free to say hello. Maybe introduce yourself if you want to, if you're representing an organization. We'd love to hear from you. But I think, Mike, I think we can just go ahead and start getting started, if that's okay with you.
Yeah, that sounds good. Thanks, Teitua. Good afternoon and welcome to everybody to our second webinar in the Equity Equation series, Power in Policy, Driving Change for Black Maternal Health. I'm Dr. Mike Royster. I'm Senior Vice President of the Institute for Public Health Innovation and one of your moderators for today. The objectives of the Equity Equation webinar series are to draw connections between regional health outcomes, health inequities, and root causes such as racism, sexism, and classism, to analyze the implications of past, present, and/or proposed policies on the health of specific communities in our region and the overall health of our region in general, explain the impact of past, present, and/or proposed policies on health outcomes, and apply policy and system solutions to public health practice. Next slide. The Institute for Public Health Innovation, or IPHI, is one of over 40 public health institutes across the country with the purpose of serving as capacity, infrastructure, and expertise for the region. IPHI serves DC, Maryland, and Virginia, and works at the policy and systems level in partnership with other members of the public health system to advance fair and full opportunities for every person, family, and community in our region to achieve optimal health and well-being. We create change by spurring innovation, facilitating cross-sector partnerships, providing training, technical assistance, and capacity building assistance, and supporting effective policies and systems that advance health equity and racial justice. Next slide. As the Public Health Institute for DC, Maryland, and Virginia, our work with and in communities across the region gives us a big picture and close-up view of the most critical and emerging public health, health equity, and racial justice issues affecting our region and nation. With this perspective, we created the Equity Equation webinar series to support our mission by convening folks from across our region and beyond to highlight these issues. Our first webinar took place on February 27th and focused on the American life expectancy crisis, its inequitable impact on under-resourced communities, populations of color, and rural regions of the area we serve and the nation, and local and state level policies and systems changes that can help reverse this crisis. The equity equation uses an equity and anti-racist lens to go to the roots of health inequities, draw attention to the underlying causes that create and sustain them, and uplift policies and systems changes that can be implemented to create opportunities for all people to live healthy, thriving lives. In fact, the equity equation represents three aspects that are vital in advancing health equity. The first part of the equation is data and research, which are necessary to understand the issue and the root causes. The second part of the equation is community perspective and participation to ensure issues and solutions are grounded in and led by communities. And the third part of the equation is the focus on policies and systems changes that address the root causes of these inequities, which ensure that solutions are focused on the social determinants, as well as the decisions that shape the quality and accessibility of social determinants for all. Each webinar will include speakers that in one way or another draw attention to these aspects of the equity equation in order to reinforce their importance and support our audience in promoting health equity and racial justice. The next slide. And I'm pleased to introduce our team at IPHI that leads these efforts. In addition to myself, there's Rebecca Epstein, Senior Program Manager, Teitua Asperi, Program Associate, and Tara Swamy, a Health Equity Intern who's working with us. Next slide. And briefly, for housekeeping, participants will be muted throughout the webinar. You can use the chat or Q&A feature throughout for any questions or comments, and the IPHI team will track those questions and present them to our speakers to respond to during the Q&A portion of the webinar. The webinar will be recorded and will be available afterwards, along with the speaker slides and other relevant information and resources. We also will include poll questions throughout the session to engage the audience. And with that, I'll turn it back over to Teitua to move us into the session itself.
Yeah, hi, welcome everybody. Thank you so much for joining us. Yeah, so, again, before we kind of jump into the amazing speakers and the presentations that we have for y'all today, I actually did want to take this time to acknowledge that this webinar is being held during Black Maternal Health Week, which is from April 11th to the 17th. And that week has been founded by the Black Mamas Matter Alliance. And it was in an effort to raise awareness, inspire activism, and strengthen organizing for Black maternal health. So again, as we are celebrating Black Maternal Health Week with you all here today, we hope you take away a few key learning skills from this webinar. We hope by the end that you'll be able to summarize trends in Black maternal health in DC, Maryland, and Virginia, describe key factors contributing to those trends in maternal health, sort of look at the social determinants of health in relation to these Black maternal health inequities, and then also identify potential policy and system strategies to improve Black maternal health and reduce inequities in our region. So we have our first poll question for you today, and let's see if we can get it launched. Perfect. Thank you so much. So what percentage of pregnancy-related deaths are considered preventable? And I'll give it a few moments for folks to answer. I love this. We're like 61 of 74 people have answered. That's awesome. It's an awesome answer rate. So, as people are still answering, a couple things that I'm seeing is, some people, the majority are saying over 80%. Some are saying 70%. A couple of people have answered 60, and a few people have also answered 50. So I'm going to go ahead and end the poll and share the results with you all. So again, that's sort of what I was seeing, is that majority of you all said over 80%. And for those that said over 80, you are correct. So, really among, pregnancy-related deaths, really we're finding that a majority of them are happening between 7 days and 1 year after pregnancy. And really the leading underlying causes of pregnancy-related death include things as mental health conditions, excessive bleeding or hemorrhage, cardiac and coronary conditions, infection, cardiomyopathy, hypertension. But really what we're seeing within the Black communities is that the leading underlying cause for them are cardiac and coronary conditions, which were leading to sort of these underlying causes of pregnancy-related deaths. I know Dr. Henry in the next couple slides are going to be kind of going over that as well. But we sort of kind of kicked off this poll question just to sort of start framing what we're talking about here. We're talking about preventable deaths. We're talking about, Black moms and mothers that are, dying from things that can be prevented. And maybe some of the things that some of the strategy solutions that we're going to talk about today are going to help sort of frame that way of thinking, that we can sort of focus on prevention instead of just reactionary causes. So I'm going to go ahead and introduce our awesome speakers for today. So the first one you're going to hear from is Dr. Tamara Henry. She's a versatile public health professional with extensive experience across various sectors. She works in consulting, government programming, and academia. She has over a decade of service in state and local governments. Dr. Henry has focused on addressing health disparities and promoting health equity, particularly among underserved populations. Currently, Dr. Henry is serving as a teaching associate professor at the Milken Institute School of Public Health at the George Washington University, my alma mater, and she was one of my personal professors at my MPH. So I'm so glad she was able to join us today. She's also a distinguished member of the Master's Teacher Academy and has received multiple awards for excellence in teaching undergraduate public health. In addition to her academic role, Dr. Henry has dedicated 20 years to collaborating with HIV/AIDS service organizations globally and partners with community serving organizations nationwide to advance equity and inclusion initiatives. Dr. Henry earned her Bachelor of Science in Biology from Howard University and her doctorate in health education from Teachers College at Columbia University. Her commitment to public health and community empowerment continues to drive her impactful work. Thank you so much, Dr. Henry, for joining us. Our second speaker that we have today is Senator Angelia Williams Graves. So Senator Angelia Williams was born and raised in Norfolk, Virginia. Senator Williams Graves is a graduate of Tidewater Community College and Old Dominion University and is a broker and owner of Homes by Angela Realty Company. She was elected to represent the residents of the 21st Senate District of the Commonwealth of Virginia in November of 2023. But she previously served as a delegate in the Virginia House of Delegates and was a council member on the Norfolk City Council, as well as Norfolk's vice mayor. As a senator, she serves on several committees, including agriculture, conservation, and natural resources, the local government, rehabilitation and social services, and transportation. And she's currently the co-chair of the Virginia's Black Maternal Health Caucus. Thank you so much, Angelia Williams Graves, for joining us today. And finally, last but not least, we have our third final speaker, and that is Councilmember Krystal Oriadha. So Krystal Oriadha was elected to serve for her first 4-year term on the Prince George's County Council in November 2022 during the general election. And now she's representing the Council of District 7. So her previous career accomplishments combine more than a decade of professional experience within the public, private, and nonprofit sectors, with her extensive community engagement to craft and support policies that build a brighter future for District 7 and Prince George's County. She's also a co-founder of PG Changemakers, which is a grassroots organization addressing community issues to include housing, food insecurity, healthcare, LGBTQ+ rights, policy reform, education, and systemic racism. She was the youngest junior project manager for Hewlett-Packard's Global Enterprise Management Team and was employed as a federal government senior communications consultant, building national campaigns around issues including human trafficking, domestic violence, and adolescent pregnancy prevention. And she served as the senior director of policy and programs for a national nonprofit. Krystal Oriadha was recognized among the 2021 Daily Record's top 100 women and the 2021 top 10 emerging leaders in food and agriculture. She was also the recipient of the 2019 Innovation Fund 40 Under 40 Award for Public Service and a 2018 Howard University Alumni Move Makers Award. And she served on the 2019 Clinton Foundation's 2030 Leadership Council. She's also a graduate of Howard University School of Business, earning her BBA in International Business. She also studied abroad in Tanzania, East Africa, and the university, while she's at the University of Dar es Salaam, and then earned her MBA from Amberton University. Councilmember Oriadha is a longstanding resident of Seat Pleasant. So now I'm happy to turn it over to our first speaker of the webinar, Dr. Tamara Henry. Everybody. All right, let's see.
Thank you again for allowing me to be here today. I'm super excited about what we are going to discuss. For the most part, I'm going to offer to you the impact of social determinants of health on maternal mortality. We're going to talk about what that looks like based on where we live, work, and play. And then we're going to discuss just a little bit about the promising practices in maternal research and maternal child health care at this point. We do have two other phenomenal experts that I'm sure will provide a lot of that really important information as it relates to policies around maternal health of Black women. So first and foremost, one of the things that we have to take into account when considering maternal mortality among African-American women is that of the social determinants of health. While a very common term for those of us who have worked in the field of public health, it is especially germane to this discussion today because the social determinants of health really consider the conditions in which people are born, grow, work, learn, worship, play, and age. And what's most important about the social determinants of health is that of the fact that the circumstances that persons are born into or the circumstances of their built environment is essentially shaped by the distribution of money, power, and resources at the global, national, and local level. When you consider these determinants of population health, a lot of folks like to discuss individual roles and responsibilities and how that impacts an individual's health, right? Is it a genetic factor? Is it just because people eat poorly or do certain things, smoke, that they have worse health outcomes? Is it because of access to medical care that impact outcomes? Or is it about the social and societal characteristics? So this is just a question for you to think about as it relates to whom you work with and what you currently do in the field. Considering that social characteristics and the total ecology account for more than 50% of health outcomes, how could you or your organizations change the way you process, learn, and work with folks who give birth? And that's extremely important because, again, what it says to us is that we cannot continue to just put the onus on individual health behaviors, and we should consider asking the right questions around what is going on in the lives of Black women who are giving birth and what some of these root causes may look like. So there are a number of root causes of health inequity, right? So we know that from the perspective of one who is in a vulnerable population, which a lot of Black women are in, we have the prenatal aspect, what is going on throughout the life course. We have the actual labor and delivery aspect, what is happening while an individual is giving birth. And then we have the postpartum, which was a question that was just addressed to you all, the fact that most of these deaths are occurring in the postpartum phase, but more importantly, they're based on preventable diseases. And before we get into the remainder of this discussion, I think it's especially helpful for us to all understand and be on one accord of what exactly is maternal mortality. What is that definition? What does it look like? So as you'll note from the slide, we're looking at death that typically occurs within that year after birth. And why that's important, as was mentioned earlier, is that some individuals think that maternal mortality is something that only happens at the hospital, and that's not the way it is. The research and the examples that we have show us completely different to what a lot of us assume. So we see just on this slide right here that post-pregnancy, or the quote unquote fourth trimester, is when we're seeing the majority of these deaths. The causes of maternal mortality, as indicated or referenced by Tetsuo earlier, are postpartum hemorrhages, primarily, as well as various cardiac issues. Now, what might that look like when we consider the distribution of maternal mortality across the US? I think that this slide is extremely important because in color, in living color, it demonstrates the state of maternal mortality in the US, with Mississippi having the highest rates of maternal mortality, and California at a 9.7 having the lowest rates of maternal mortality. So a couple of things can be inferred by looking at this map. You'll note that the places in the region that have the highest rates of maternal mortality occupy the Bible Belt, or most of the southern states. And when we begin to discuss policy later on, this is also germane to the discussion, the fact that we can look right along the southern region. And I want you to consider some of the policies that are happening right now in the southern region as it relates to Medicaid expansion and other things that could possibly contribute to maternal mortality. So instead of thinking about this as an individual behavioral issue, consider the systems that are in place that are further impacting Black persons who give birth, but also what those systems may look like in relation to poverty, education, et cetera, as it relates to maternal mortality. So we're looking at how the systems directly impact the mortality of Black women. So as we begin to, again, explore these rates, especially in our immediate region, it's important to note that maternal mortality is prevalent amongst Black women regardless of education level or socioeconomic status. This particular slide, and we have some data from 2008 to 2012, that suggests that Black college-educated mothers who gave birth in local hospitals were more likely to suffer severe complications of pregnancy or childbirth, pregnancy during childbirth, rather than white women who have never graduated from high school. So I want you to think about that even when we account for education and socioeconomic status, which are typically indicators of better health outcomes, even with those things intact, Black women are still more likely to die via childbirth, after childbirth, than a white woman who has a high school diploma. Those are the facts, those are the data. The most recent US maternal mortality ratio suggested about 17.4 out of 100,000 pregnancies represented approximately 660 maternal deaths. We are ranking the lowest, actually not just the lowest, but last among industrialized countries, and we should be absolutely ashamed of that. Further, the maternal death rate for Black women is 2.5 times that of white women and 3 times the rate of Hispanic women. So it's really important for us to get to what the root causes are and what is happening. We have data, we have anecdotal stories, but what is happening in the systems, in the life course of Black women that continue with these deleterious effects. So you all may have recalled or heard about this particular story in the most recent news, I believe on March 20th. Krystal Anderson, a former Kansas City chief cheerleader and yoga instructor, died at the age of 40 after giving birth to her stillborn daughter. And why this is important: 1, it hasn't even been a month since she died. 2, she was trained as a software engineer before becoming a Kansas City cheerleader. 3, she was 40, died from sepsis about a month after giving birth. And that, again, is problematic. We're talking about someone that was educated in good enough health, but this particular pregnancy that was also a stillbirth was her second stillbirth. So this happens every day. Sometimes it makes the news, other times it doesn't. But I want to bring this story to your attention because this is how common this has become in our society. And as public health professionals, we should be seeking how to address this issue. It is extremely common, and we sometimes get a wind of it in the news, other times we don't. In the interest of time, I am not going to play the video, but you will have this slide deck and you will be able to play it at your leisure. Now, as it relates to Washington, D.C., we are higher than the national mortality rate at 20.7, which is what it is nationally. The rate for DC is 70.9. While Black people accounted for about half the births in DC, they suffered 90%. So I'm going to say that again. Black people suffered 90% of birth-related deaths, according to the DC Maternal Mortality Review Committee. So we are unfortunately exceeding leaps and bounds as it relates to maternal mortality here in the district. What I'd like to also bring to your attention is what this structural inequity looks like. So you recall I said we have to consider some of the systemic things that are happening. This is not happening by happenstance. It's in a controlled environment where we have a system that is not working. For the purpose of this example of structural inequity, consider the maternity desert that often resides east of the Anacostia River in Washington, D.C. In this district, there's a history of local and federal policies that structurally disenfranchise people of color. There's no hospital east of the South Capitol Street or east of the Anacostia River. The obstetrics ward at United Medical Center was closed by the DC Department of Health for repeated violations and never reopened. And yes, now going forward, about 2023, there's a new hospital that's expected to open at St. Elizabeth East Campus. But we really need to take into account what has occurred east of the river that continues to impact persons at the rate in which we see. Other socioeconomic factors that really impact this particular section of DC that often is permeated throughout the district as it relates to people of color, or other things that we think about when we consider systemic inequities. We know that there is not only a maternity desert in wards 7 and 8 or east of the Anacostia River, but there's also a food desert. So we have to consider what are the implications of not only having a maternity desert, but a food desert, and also having that particular region of the district having lowest socioeconomic status. So you call it a trifecta or any other name that you can think of, but what it is we're seeing concentrated levels of poverty in certain places that are further exacerbating our quality of life for women giving birth in the district. In addition, we know that about 1/3 of women in DC have more than one chronic health condition. And as stated earlier, women are dying of preventable diseases. So if you're already at the 1/3 mark with a health condition, this could be also problematic. In the US, almost 40% of women had more than one chronic condition. So think about how that may impact an individual who goes to give birth with all of these other conditions. Almost 70% of persons who have chronic conditions are more likely to have a preterm birth. And with respect to birth rates, we also recognize that DC has a high rate of these preterm births at about 63%. And again, the concentration is in a particular area and region of the district. Now, at a glance, I'm not going to get too much into Maryland or Virginia because you have Maryland and Virginia experts to also discuss the vision for maternal mortality in those particular regions. But I think, again, it's important to look at the data as it relates to the average maternal mortality rate for Black mothers, which in Maryland was 4 times that of white mothers. And in Virginia, you'll note that there is some variability, but we will note in this particular slide that 113 Virginia mothers died from pregnancy-related causes, and that the maternal mortality rate for Black women is twice the rate for white women in the state of Virginia. So let's, again, look at the social determinants of health effects on maternal mortality. We know that there are a number of levels in which you can address this. Some of you may be clinicians, some of you may be policymakers that are on this webinar, and it's really up to you to consider at what place in this concentric circle that you and your work may be most effective. So it could be at the individual, at the societal, relationship-wise, or at the communal. And essentially what that concentric circle represents is if we are all working in tandem, meaning diverse ways of thinking, innovative ways of thinking, if we're all at the table, we should see better maternal and infant mortality outcomes by taking into account those societal factors inclusive of food, better education, livable wage, housing, etc. There are a plethora of solutions that we're not going to get into fully because, again, there are 2 other individuals who will be discussing some of the political or policy aspects to address infant and maternal mortality. But one of the things that I think would be most helpful when we consider achieving maternal mortality, achieving better outcomes for persons who are dying at childbirth is considering the structural inequities and addressing those issues, not to mention how our clinicians are trained as it relates to working with Black women who are giving birth. One way to do this is improving awareness via preconception. So for some persons who are planning to get pregnant, what might that include? We have it from the physician's perspective, training folks about biases, recognizing various disparities that occur amongst persons who give birth. The one that I love the most is expanding postpartum care, recognizing that because we're seeing most of these deaths 1 month to almost 12 months after a person gives birth, what could expanding postpartum care look like? From a policy perspective, addressing it from a Medicaid perspective especially, but if we know that most deaths are happening, then what can we do as a system to recognize that and address it accordingly? As noted again, extending the coverage, extremely helpful, addressing racism in our current systems, eliminating these maternity care deserts that I discussed in DC, as well as other places in rural environments, we see the same challenges occurring. Investing in our community programs, having more peer-to-peer models where mothers who are pregnant, persons who are pregnant can teach other persons about experiences. There are birthing apps to address what hospitals are best for persons who are Black and giving birth to use. So that could be another manner of doing so to have better health outcomes. In closing, I think that if we are all on one accord about how to achieve maternal health equity as it relates for Black women, we have to reframe the conversation about health, recognize that our education and experience can affect health equity in all policies because we're going to need a holistic approach to address this as well as a systemic approach. Determine which root cause is most feasible to address among your population and commit, because we recognize that we're in all different parts of the circle and different parts of the field as it relates to maternal mortality. In addition, to just be an authentic ally takes practice and requires full acknowledgement of the impact of systemic racism on adverse health outcomes. And to close with one of my favorite quotes, washing one's hands of conflict between the powerful and the powerless means to side with the powerful and not to be neutral. And that's from Paulo Freire. And that concludes my presentation for today. I can't wait to hear your questions. Thank you for your time.
Thank you so much, Dr. Henry. And again, yes, please use the Q&A function because we will have a question and answer panel after all the presentations have been said. So I'm going to go ahead and now kick it off to Senator Angelia Williams Graves.
Okay, so I think "you're on mute" is still the phrase that is coming over from COVID. Good afternoon, everyone, and thank you so much for being here. It is really wonderful to have so many interested parties in making sure that we have better outcomes in Black maternal health in Virginia, and not just in Virginia, I believe across the country, because this is a problem that not only affects Virginia, but it does affect those across the country. I am Senator Angelia Williams Graves, representing the 21st Senate District in Norfolk, Virginia. And a couple of things I believe one of the reasons why this is important to me is, as a legislator, that's where I believe I can be most important. But in terms of making sure that we have policies in place that are beneficial to our practitioners, policies in place that help to protect the public, and to make sure that we have funding for those policies as well. And then on the side of raising awareness, being informed, and being informative. And so we're going to jump in and talk about how inequities in Black maternal health play out in Virginia. So as you can see on the slide, the mortality maternal mortality by race. And in a study that showed between 2018 and 2021 that the maternal mortality rate for Black mothers was twice the rate of white mothers. And so one of the questions that we asked, which has, been very well stated by the doctor, is what are some of the causes? Is it lack of information? Is it lack of access? Is it overall poverty and the challenges that come with living in poverty and just trying to survive day to day yourself, and then carrying a little one and being responsible for that person that's inside of you as well. In our state capital of Richmond, infants born to Black women die at a rate of 1.5 to 3 times more than compared to other races. And we just find that that is an unacceptable rate with all of the advances that we have had in healthcare in general. And all of the advances specifically in OBGYN and gynecological care, we find that that rate is just unacceptable. The VCU Health Patient Experience surveys lower satisfaction in quality care for Black patients as compared to white patients in their maternal inpatient ward. And so just small things that in working with our caucus on maternal health care, being believed is something that women are finding that they're having problems with. These different kinds of assertions that Black women have a higher tolerance of pain. So therefore, when we say we're in pain, it's really not that bad. And so we want to, in addition to working on the policy side, we want to work to eliminate those misnomers about whatever biases and misnomers that doctors and practitioners come to the table with. We want to work to eliminate those so that women can, one, have good open dialogue with their doctors, and two, be believed when they say they're having various experiences, as well as have the ability to be proactive in the care that they receive, knowing that Black women are have a higher exposure rate to certain illnesses and conditions, making women aware so that they can do what is necessary in order to have a healthy, happy pregnancy. Policy levers that we can talk about to address Black maternal health and the inequity of maternal health in our community. You can go to the next slide. The Virginia Black Maternal Health Caucus is a caucus that we started this year, this legislative year. And it's a caucus of Black women in the Virginia General Assembly, made up of senators and House of Delegates members who really feel that these metrics need to be addressed and that we are in a position to be able to do that, to do just that. The caucus does meet periodically to discuss inequities in maternal health. We are looking for external partners to partner with and helping us to, number one, find solutions legislatively, but also working with the community in order to be able to get information out, that being informed and informing part that is very, very important to us. And how can we make sure that every mother has a successful pregnancy? And I appreciate something that the doctor said about extending postpartum care, because that is something that I don't think that women think about when they're pregnant. You have your baby and everything is just supposed to be happy, happy, joy, joy. And oftentimes it's not. And there's no quick fix to finding a solution to sometimes to what's going on when women are adjusting to becoming new mothers. And so that extension of postpartum health care is one that I'm definitely going to take back to the caucus, because I believe that we kind of feel like because we get 12 weeks off for in some cases we get 12 weeks off for giving birth, that everything comes together in those 12 weeks and we just go back to normal and we have a whole new human being, and we're trying to still figure out what normal is. And so one of the things that I'm very proud of is the space that the Black Maternal Health Caucus gives us for having these conversations, not only with each other as Black women, but also with our white counterparts, also with our male counterparts, who are oftentimes the providers, also with those folks who may not always have English as their first language. And there may be some language barriers there, but it gives us an opportunity to have those conversations with them to help to dispel some of the misnomers and to work through some of the biases that may come into the I was going to say the operating room, but that's not exactly right, but come into those patient settings that women have when you're going through a pregnancy. So we want to make sure that we're advocates for that. And then this past legislative year, the governor signed a resolution that would bring into law and designate the 11th through the 17th of April as Black Maternal Health Week. And so our goal is to utilize this time every year and all of the time in between to make sure that we are bringing about awareness to the Black maternal health cause, and then also working with our counterparts and working with our partner organizations to bring about legislation that will be beneficial. Sometimes, oftentimes, the best legislation that we find is legislation that comes to us from those who are actually doing the work every day, because we may have an idea of how something should happen, but those practitioners that are in the settings every day can give us better advice on what is practical and what is meaningful and what will help you to get the best outcomes for our Black mamas and our Black babies to ensure healthy pregnancies. Let's see, where are we here? All right, so policies. So we're going to go to the next slide in policies. This legislative year, we have 3 policies that I'd like to highlight. That's House Bill 204, which added members to the maternal mortality review team. So the more members that we have, the more input that we have, the more factual information and day-to-day applicable information we have, we can again come back to creating legislation that is actually beneficial to making sure that we're getting the best outcomes and having the best success. Then we have House Bill 831, which creates a work group to expand the work of the maternal mortality review team. And all of these bills, if I'm not mistaken, received bipartisan support. And so that really is something to be proud of, but it's also something that says this is, really a problem when we can get support on both sides of the aisle. And then House Bill 935, which requires health insurance to provide coverage for doula care services. So oftentimes when you talk about women who may be in poverty or may not have a level of education, and even those who do, they don't know what to ask, right? If you're having you don't have babies every day, not one woman anyway. And so what we find is that women don't know what to advocate for, and things may change in the medical world between your first child and your second child. And especially it can be scary when it's your first child and you're getting all this information online and you're getting all this information from friends and family, and people mean well, but they don't always they're not always the best sources of information. And so having a doula with a young mother or with a mother in general to ask the questions, to be the advocate, to have factual information, to be able to also maybe identify if a mother is exhibiting symptoms that may be problematic to her pregnancy early in the pregnancy. Those things are key. And so getting healthcare providers or requiring healthcare providers to provide coverage for doula care was majorly important for us in this past session, because that's going to really make a difference in the outcomes and the successes for maternal health. And then last year, House Bill 1567 created a work group to evaluate strategies that reduced maternal and infant mortality rates and to make recommendations to enhance maternal health and public health support systems. And Senate Bill 1254 requires a maternal mortality review team to annually compile statistical data and make that data available to the public. So ideally, what we're doing is not just taking information, but we're taking information, putting it together, creating legislation that will be helpful and effective not only to providers but also to parents, and moving the needle on Black maternal health outcomes, because we want to make sure that all of our babies and mamas have good experiences throughout the pregnancy process.
Thank you so much, Senator, for sharing your presentation with us and for sharing some of the great work that the Black Maternal Health Caucus is doing, and some of the work that the Virginia Senate is doing. So thank you so much. And we're excited for the work that you guys are doing too in this upcoming General Assembly. So thank you for joining us, and I am happy to then now introduce Councilmember Krystal Oriadha.
Thank you so much. I am looking forward to presenting. Give me 1 second to share my screen, everyone. Everyone can see it? Awesome. So I'm Councilmember Krystal Oriadha. I have the pleasure of representing District 7 in Prince George's County. And as you can see, I'm a new mom. So that is a picture of me and my baby on the dais. I think there he's probably 3 months old. He is 5 months as of now. He'll be 6 months this week. So when we talk about addressing the issues and challenges that we face around Black maternal health, and I'll talk about the challenges, especially when we think about it from a majority Black county. So if people aren't familiar with Prince George's County, we are known and pride ourselves as being one of the most affluent, wealthiest Black counties in the country, right? And so what's important here is when we talk about racial disparities in care, the reality is that a Black community, our ecosystem, right, does not erase internalized racism and how it shows up. And so that's really important for me to always name, is because I think sometimes when we talk conversations around equity and, especially racial justice, sometimes people think the lowest hanging fruit and the way to address it is just by hiring Black people. And that is not it, right? There is so many things that you have to address when having a conversation around racism and how it shows up and how you break it down, especially from the lens that we're talking around healthcare. And so I just want to frame the conversation in that because I think sometimes that's all people think it is, and it's so much more than that. One of the things in Prince George's County that's really important to notice, and that the doctor mentioned before, is that we have that healthcare desert, like where we have a lack of practitioners. And so when you look at Prince George's County and the state of Maryland, we have, for example, one of the worst emergency room wait times. And one of those reasons is because we don't have a lot of practitioners and we don't do a lot of preventative care. And so we end up seeing so many people in our emergency rooms. We also have to look at there is a lack of investment. Historically, the issue around maternal care and the issue specifically around Black maternal health care has not been invested in, right? Hasn't been invested in when it comes to like grant dollars and resources. And it also hasn't been a concentrated effort to even focus on this issue. And then when we talk about representation, I think that it's fair to say there's been a lack of people in positions of power that actually care about this issue. And that also matters. So I want to talk a little bit about the policies we have centering mothers and specifically Black mothers that I've been able to work on over the last year, because this is my first term. So this is my first year in office. So first I want to talk about representation, right? So this is virtual voting bill that failed but then passed. And why this is important is just to label the context around how we don't have a lot of people at the table that even understand this issue. When we talk about heads of state around the world, not just talking about the US, we've only had one person ever to serve as head of state and give birth during their term, one in New Zealand. When we talk about people in Congress that have given birth while serving, there's only been 10, period, right? And here in Prince George's County, I was the first. We never had a woman that had been serving, but also pregnant at the same time and gave birth. And why this was important is because there was no policy around it. There was no leave policy for me. And so if I wanted to go on maternity leave and it was going to be at the end of our session, meaning I would miss all of the most crucial votes, I would have given up my representation, the only option for me was just to leave. And when I asked for a maternity leave policy, at first it was voted down. My colleagues said they did not believe in giving reasonable accommodations for elected officials that are pregnant. And so it took the community rallying thousands of people, signing petitions, coming out and protesting, coming to speak in the council to change it. And why that's important is that if we continue to not create a space in these bodies that allow those women to sit at the table, then we're going to continue to not have those pieces of legislation really move forward. Next, we have Black Maternal Health Fund. So what is also really important is funneling the resources. So I passed legislation to create a Black Maternal Health Fund, and my goal is really to focus on funding doulas. It's one of the things that we have seen a lot compared to other jurisdictions that have a robust doula outreach, have a real investment in it, and we don't have that here in the county. But here's the key. I always say the legislation, we passed it, but is it funded? No. And so I always tell people, yes, we want to fight for the legislation, we want to fight for the programs, but don't drop the ball and don't think it's done. And a lot of elected officials will sometimes say, yes, we passed it, and they'll never come back to the fact that it's not funded. It is just sitting there as something that they can say they did that's not actually actualized in any way that impacts the community. And so I'm really big at being transparent that the next thing we have to do is fund it, because it means nothing that we created the mechanism if we don't actually fund it and get the resources where they need to go. Next, pass legislation around a child care incentive program, because I think this is a part of the conversation that also has to be talked about when we talk about maternal health care, right? Because when we talk about, especially after the child's here and postpartum in the 4th trimester, there's a hope that a lot of women will be able to stay home and they want to be able to be with their child, but the reality is that a lot are not. And one of the things I hear is that a lot of them will tell me that they can't afford to go back to work. And so that just pushes them further into some poverty situations, because they're trying to balance the idea of how am I going to pay for childcare? How am I going to then take care of my child and give them the basic necessities? So I passed this program to create an incentive program for small local businesses to provide childcare. But again, it's passed, but now we're asking, my colleagues and our county executive to fund it. because we have to put the resources there. Next, a maternal health care audit. So one of the things I realized when I was pregnant was that as a county employee, the provider I had did not even allow me to give birth in my county. I had no option. So I had to drive out to Montgomery County for my checkups, give birth in Anne Arundel. And I thought to myself, how could we not have access for any woman that works for this county government to even give birth in this county? And then it made me think about all the other, when we talk about benefits, when it comes to like doula, when it comes to other benefits that we have, thinking outside the box. So we created this audit that allows stakeholders to come to the table to look at all of our healthcare that we provide with a main focus on maternal health care, to give recommendations on how we can create different policies and procedures and look at the best standards across the country. And pending legislation. So there's a few things that I'm working on. And when I framed this legislation, I thought that some of this stuff would already exist. And it just was mind-boggling to me that these were things that I needed to do. But it goes back to why we don't have why when you don't have representation, it matters. So mandatory lactation rooms. Right now, we as a county aren't even meeting federal standards, right? And so when we talk about making sure that mothers have access to coming back into the workplace, making sure they have access if they make the decision to breastfeed, these are all things that are part of that ecosystem, right? Of making sure that a mom has all of the resources that she needs. That has to be part of the conversation. Also, parental leave. So this was a big one. In Prince George's County, when I first started working for the county, I used to be a policy director. The county only had 5 days of parental leave. If you wanted more, you needed to borrow, dig into other aspects of leave. I pushed the councilman I was working for at that time to increase it, and he got 10 days. Now I'm here, and so now I'm fighting for 20 days. And so my goal is to continue to up the leave, because that's part of it, right? If you can't talk about postpartum care without making sure that the mother has time to be at home, to bond with her child, and not have to worry about the leave situation. And it's important for if there's a 2-parent household for the other guardian as well. And for my situation, this was something that really mattered to me because my fiance could not take leave because he had started this new job and he was 1 week off from my due date to his 1 year of employment. And so they said, you can take unpaid leave. That's your option. And so that sparked me to change this policy that you don't have to work for the county a year, that you get the floor of 10 days from the first day you start. And then we negotiated 6 months to get the 20 days. And so it's really important because it doesn't matter when you start, the baby's coming, right? And so creating that access point to leave is important. And I think we could do a lot with policy, but there's also things we can do from like programs and initiatives as elected officials or people in power. So one of the things that was really important to me from my journey, I'll share a little bit about it. I had a horrible birthing experience, I will say that. You know, one of the examples of what it is to be ignored as a Black woman, and it's important to frame that because I fall into those categories that they talk about of, you know, upper middle class, educated, but elected official, and all of those things did not matter. I was a Black woman at the mercy of a healthcare system. And so in my situation, they didn't believe me when I said I was in pain. I told them that I respond different to pain. I have a high pain tolerance. I'm not going to scream, but if I tell you I'm in pain, trust me, I'm in pain. And I said it for hours. And they said, well, you're not screaming, so we're not going to give you pain medication. We'll come back in. They didn't check my cervix. I asked, when are you going to check again? You know, it's been a while. So to say I was in 10 hours of active labor, unknown to the doctors or the nurses. Once I demanded a doctor come see me after I'd been throwing up, had extreme pain, they realized I was crowning. And the whole time they told me I wasn't even having contractions, right? And so that moment put me into high gear and holding that hospital accountable. And I said, what can we do to make sure that this never happens to another mother that comes here? And so they are launching a pilot called Team Birth. It's this shared decision-making model that will be rolling out in this hospital. And so it'll have a whiteboard that'll be in key rooms. And one of the main things is this patient-facing planning board. And so everything that you talk about with your doctor goes on this board, right? And then they build in huddle time to not only onboard if there's a shift between nurses or doctors, but also the patient, and do it right there in front of them. It keeps all of the birthing plan in sight. So they knew I wanted an epidural. That did not happen. I had 100% natural because by the time they realized I was in labor, it was too late. But if we had had that, right, and there was a constant reminder or constant talking as they shifted to nurses from the next nurse, that could have been the difference, because it would make everyone come through and just pause and then just talk and recenter us. And so that's a pilot that they'll be launching at that hospital moving forward. Black Maternal Health Initiative. So I've launched this initiative with the Hands of Melody, which is a doula-run organization to focus on the 4th trimester. This is really important to me because I think there's not a lot of focus on the 4th trimester. So we're doing panel conversations, Instagram Lives. We launched different resources, and we're doing a Meet the Doula event. So it's really focusing on the 4th trimester in a way that it has not been focused on before. I'm launching a Black Mother's Guide that launched today. So it's a toolkit that has resources and tips. So it has different resources in the county. So diaper pantry that I'm sponsoring, the doula program, She Rises that focuses on teen moms. It also has tips of like, if you're nauseous, or how to eat healthy, how can you exercise while pregnant? Then it also has mommy blogs, specifically highlighting Black mothers that blog. And then it has a space if we don't have you highlighted and you want to be part of this resource guide. So it'll be an ongoing online database that's specifically focused on Black mothers, and it'll be growing. So I'm really excited about this because I think this creates like a one-stop shop around Black resources, specifically in Prince George's County, but it's broad to the DMV as well. And here's my contact information. And I'll just end by saying this. I think that we have to do everything when it comes to addressing Black maternal health. We have to address every aspect. We have to address mental health. We have to address the ability to work. We have to address your access to care. We have to address systemic racism. And so this is going to be something that's way bigger than a week, and it's going to be way bigger than the moment. I'm glad that there's a moment right now across the country where people care about Black maternal health. But what we have to do is make sure it's not a moment, and that this is a movement, and that it doesn't stop. It's the same way I feel about Black Lives Matter. It had to be more than a slogan. It had to be actualized with policy and change. And so I'm hopeful that this is that too. Thank you.
Thank you so much, Councilmember Krystal Oriadha, for sharing your story with us, for being vulnerable with us. I think we all really took it to heart and have learned a lot from what you're doing there at PG County, and maybe things that we could do locally here. And so I invite you all now. I think we're going to be going to our Q&A portion of the webinar. And so I'll be handing things off to Rebecca Epstein here at IPHI, who will be moderating the Q&A. But again, we hope that you all use that Q&A function, which is at the bottom of your screen, to submit questions for the panel. But I'll start off with handing it over to Rebecca.
Great. Thank you so much, Tetua, and a special thank you to all of our panelists today. I see so many reactions of people clapping, hearts, a lot of congratulatory messages for you also, Councilwoman Oriadha. So thank you all. You each presented a very unique perspective, unique information, and we're so grateful for that. I'd like to kick off the Q&A by just recognizing that this is not a new issue, and a lot of the things and the themes that each of you touched on there's a lot of variables and factors in our community and in our history that have got us to where we are now. And that can feel so big and hard to know what to do. We have audience members representing a variety of perspectives, of organizations, of roles across the DMV. I'd like to ask each of you, kind of acknowledging the diversity of our audience, acknowledging how big this can feel. What are 1 to 2 actions our audience could take after this webinar to do something in their communities to impact Black maternal health? An easy question to get you started. And this is for each of you, so whoever would like to go first, please chime in.
I'll chime in. I think that one of the things that we can do, or that folks can do who want to be helpful, is utilize social media for good in terms of getting information out there. We know about the Black Maternal Health Week, posting information to that. Any of the information that you may find valuable from this webinar, posting that information, and then just having the conversation with family and friends, and getting involved as much or as little as you want to, because everybody does. We all do things differently, but I believe that the more conversations that we're having, the more we draw people in. And so even something as simple as asking the question, hey, Facebook family and friends, do you all know that this is? And maybe a link to a resource to help have that conversation, or to just let folks' minds start running. I'm not a mom, but this is still important to me. And so it's not that we have to be involved in it in order to have it matter to us. And I think we don't always realize our level of influence with other people. And so if we talk about it, we start the conversation for other people to talk about it.
And I'll just add, I think one of the most important things, especially to push policy, is to make this a voting issue. I said that to everyone. If you want something to matter to a body of elected officials, make them feel that you will enter into a ballot box caring about how they acted on that, right? And so I think the more that we judge people on the way in which they center Black people, and in this moment, Black maternal health, then the more that we're going to see a shift, especially when it comes to policies. Because I think the reality is that they believe it doesn't matter. Like, people in positions of power, especially elected officials, think it does not matter how you treat Black people. It definitely does not matter how you treat Black women. And it won't matter. People will say something on social media, think about it for a moment, and then still vote for you. And unless we change that, the sad reality is that they're not going to change, because the majority of people that sit in seats like mine don't care. And, they hate that I say that, because I'm very transparent. I'm an advocate at heart. I am not a politician. They just don't. And it's the reason I decided to run, is because I was tired of being promised things that I was never going to get.
Thank you, Krystal. I tell you, these bison women, these Howard women, I don't know about them. I do agree wholeheartedly with both of you. I think, again, from an education perspective, I train future leaders, some of which go to medical school, or are currently in medical school, as well as physician assistants. You just mentioned it, Krystal, that bias is inherent. Right? I tell students all the time, public health and politics go hand in hand. Watch who you vote for. So with that said, I think, again, decolonizing, we hear that term a lot, decolonizing the curricula, and really having honest conversations about why those biases are the way they are, why we feel the way we do about particular people, and also addressing Ms. Haynes and one of her questions about using midwives or using alternative folks in the birthing experience. One of the things that I think is fascinating, and we don't pay a lot of attention to it, my mentor, curated 100 Years of Midwives at the Smithsonian, and she was looking at how the diaspora, particularly Senegal and Ethiopia, what those birthing practices were, and how, guess what? Black women were living with no medication, without people that didn't have MDs that pushed babies out, rearranged breech birth babies, and had successful deliveries. And of course, in modern medicine, people would be clutching their pearls at the idea of using midwifery practices or doulas, et cetera, to really advocate on behalf of those women. So on my end, I would encourage folks who have the abilities and access to consider some other ways of giving birth. And again, not to take anything away from medicine, but it has not done right by us thus far. So what are some of our other options? And what about the considerations? Because again, to that point of midwifery, we know that persons who typically do that are not Black women. So is it an access issue? Is it because they don't know about it? What are some of the things that we need to do to employ some of these alternatives that have better outcomes for Black women, to have that just in the scope and have that in the discussion? I think that would be also helpful and a point for consideration. So thank you, Ms. Haynes.
Thank you so much. So impactful to hear these firsthand stories and experiences from each of you. Really appreciate you being so open and sharing your recent birthing experience, Councilwoman Oriadha. We also had a few folks in the Q&A share similar experiences about trauma that they've experienced in this space. I appreciate you all touching on alternative strategies that may be available to kind of take women away from these places where they've experienced harm into a birthing space that is more comfortable and appropriately addresses some of this institutional harm. As of yet, I don't believe these are large-scale solutions that we've seen in our community. I'm wondering if you all have any thoughts or on what we can do as a community to make these more accessible and to start to address this institutional harm that has historically been so pervasive.
I think the Senator and Councilwoman discussed some of that by way of using social media for good. I think that in our communities in of itself, we need to have more of this discourse. There is a great deal of fear around going to a practitioner who may discriminate against you because you have Medicaid, or discriminate against you based on where you live, or discriminate against you based on this may be your third or fourth pregnancy. So there's so many other things that factor into it. I was recently on another panel where I heard about this app. The woman called it a Yelp for hospitals for Black women giving birth. I believe it's called an Earth app, IRTH. But I think that is a phenomenal way to begin to engage with one another. Where are the places that we should go and we shouldn't go? Because having that on a Yelp type platform is not only innovative, but it's awesome, because that is the way people communicate, especially if for whatever reason you're embarrassed or you don't want to talk about this. You feel like this is your private information. Having that at your fingertips is helpful. For persons who have given birth and may be experiencing postpartum, how about talking about that? That is a real thing. The birthing experience could be overwhelming, and you have a right to feel down. Who do you talk to about that? Especially, who do you talk to about that when you have no health insurance, or the health insurance you have doesn't apply to that? You have to pay out of pocket for any sort of counseling services, any sort of anxiety related to the birth of your child. So I think things like that, we really need to be far more community-based and community-oriented, and recognize that culturally, we've been taught that a lot of this is personal business, and we don't talk about our personal business with people we don't know. So recognizing that there are a number of cultural barriers that we have to place to the side by forging an authentic, trusting relationship. What does that look like? looks very different to people based on whether you're from the diaspora, African American, Southern folks versus Northern folks. But I think that starting that discourse and having people feel like you are that trusted resource could be very helpful.
Thank you so much for that, Dr. Henry. And I would love to add, we've already heard a couple of solutions presented through the presentations already in the Q&A. There's a lot of brilliant minds in the audience as well. So please feel free to share in the chat if you have seen something, especially from this community-based model, that has been very impactful in your own community or a neighboring community as well. We'd love to hear more and learn from each other in this space. One question that has certainly come to mind throughout the different presentations, hearing this strong theme on bias, implicit bias, especially on part of providers and the healthcare institution as a whole. This question, I'm in Virginia, so this question is a little more Virginia specific, although I would love to hear if there are other pieces of legislation that are similar in our other jurisdictions in DC and Maryland. But I know there's I believe pending legislation in Virginia that would require implicit bias training for all providers. So I don't know if it's too early or too soon to comment on that, Senator, but would love to hear if you're aware of any progress that has made and what that could look like for maternal health providers.
Thank you for the question. And I'm not. Unfortunately, we are combing through governor's amendments and vetoes as it stands right now, getting ready to go back for a veto session actually tomorrow. Veto session is on Wednesday, but it's definitely something that I am will keep my eyes on to determine whether or not the bill was vetoed or what the amendments are. Because oftentimes what we find is that bills will get amended and then they are useless, or the amendments are basically a substitute and they change the entire intent of the bill, of the original bill, once they get to the governor's office. And so I am one that I don't like passing legislation just to have a high pass rate if it doesn't do what it's intended to do, and amendments don't make the bill better, or if it's not a reasonable compromise, then I am not inclined to vote for that, because oftentimes those types of amendments or substitutes end up doing more harm than good, because then people say we did something, we can just move on. And what we did was really worthless. And so my goal is always to pass meaningful legislation that allows folks that when implemented will go to some of those things. You mentioned broad changes, and broad changes come like you eat an elephant, one bite at a time. And it's a lot of small things that come together to make a powerful change, simply because this is not an issue that is a one size fits all. As I'm listening to the councilwoman and to the doctor, I'm hearing different things and even looking at perspectives that I had not considered in this space of what problems are. And when we talk about bias, which is huge in this, what we have to realize is that everybody comes to whatever table they are sitting at with the experiences of their lifetimes. And that's what cultivates how we see other people. Bias is really just how we see other people, what we think of them, what are our automatic thoughts, what are our automatic fears, what are our automatic assumptions. And what we all have to do, I think the very first thing we have to do is realize that we all have them. We can't, it's like the 12-step program. We can't solve the problem that we are not willing to acknowledge even exists. And so once we say that we have biases, it doesn't mean I'm a bad person. It doesn't mean I'm a horrible human being. It just means that my life and my pathway to getting here is different from every other human's in the universe, and we all come to the table with that. And I want to just add that one of the solutions is having women in elected office. And the reason I say that is because we built the new General Assembly building, and in charge of the new, in charge of the architecture and the features and the build out and all of the things that were going to make that building functional was the first female Speaker of the House. Okay, 3 years ago, our first female Speaker of the House, and our Senate clerk, who is a woman. And at the time when we had a Speaker of the House who was a woman, she had a clerk who was also a woman. And so we have lactation rooms, and we have family bathrooms, and we have all of those things in this great and grand, in addition to Wi-Fi and, you know, all the techie things that we need to do our jobs, but we have all those considerations. And I would bet money, almost, maybe, that if men were in charge of the build out and the architecture and the construction and the features and the benefits, those are things that would be oblivious to them because it's not a part of their daily lives or a part of the daily lives of their friends. And so it's just like purse hooks in a bathroom. Men don't think about that, but we do, right? So those are the kinds of things that when we have women in elected spaces, when we have women in powerful positions, those things make a difference in how policy is crafted and the considerations of others comes into effect. And for people who may not think this is an issue, you know, we have the privilege of being elected. And when we say jump, people usually say how high. When the elected official says jump and nothing happens, that's a problem. And so if that happens to an elected official, then imagine what happens to folks who are perceived to be powerless, for people who are perceived to be less than, for people who are perceived to not have the wherewithal. And this is something that just kind of speaks. The more I talk about it and the more of these conversations I'm engaged in, even though I'm not a mom, it just the experiences that women have to have in what is supposed to be the most joyful and joyous times of their lives, and it's not, that just infuriates me, but it motivates me to be a part of the solution and not just sit back on the sidelines.
And I just want to add to, I agree with everything she just said. And I think too, a second layer when it comes to like the bias is the training is important in making sure that people have access to all of the information, but there's another part as well that has to be added that I think is rarely talked about, is the accountability for intentional racism, because everyone kind of has a conversation around it being like microaggressions, but there's like just intentional harm being done. And the reality is that we can do training and we can have a conversation, but then sometimes there also needs to be just firing. Like, you are no longer allowed to care for people in the healthcare system because you are racist, right? The same way I feel like you should not be able to carry a gun and a badge if you are going to kill unarmed Black people. The same way we need to translate that into the healthcare system, because we are dying and it's preventable. And there's some people that feel that we are less than, or we brought this upon ourselves because of perceptions about our lifestyle, and we're obese and we're this and we're that. And so therefore it's warranted on us, and there's a lack of consequences for it. And so I think, you know, one of the things I'm really trying to figure out how to do is intentionally build both. It's like, yes, we want to train, and yes, we want to make sure the resources out there. Yes, we want to build more processes, but I also want to make sure people are held accountable in a real way, because our country has moved back to acceptable racism, right? Racism has always existed, right? We just went into an era where you needed to be a closet racist. Now you can be back to being an open racist. And so how do we make it so, because we're not going to make everyone stop being racist. That's just not real. But what we can make people feel like is that there is fear in being one, and it won't be tolerated, and there will be tangible consequences for your actions. And so I want to make sure that we build that type of fear for people that are practitioners into the healthcare system, because I think we have to if we want to save Black lives.
Thank you so much. Really powerful messages to take away and absorb. And I just want to also kind of put a shout out and recognize in the questions and throughout the chat, there's a couple of groups who have shared their information or talked about coalitions. And just to kind of put a little bit more behind that, there's always power in number, and shout out to coalitions and how we can really help each other elevate these stories and bring attention to the masses. So thank you all so much. As a closing question for the Q&A, I just wanted to ask one more question, which is,
Hey, Rebecca.
Yes.
Hey, Rebecca, I just got my wonderful staff. They are great. They just gave me an update. House Bill 1130 is the bill that you're referencing. And it was amended by the governor. So when we go back on Wednesday, we'll be taking action as to accept or reject his amendments. And if his amendments are rejected, then the bill in its original form will go back to the governor, and then he will have the opportunity to either sign it into law, veto it completely, or do nothing and let it pass into law without his signature. And she's Caroline's gonna put the link to the bill in the chat as well.
Thank you so much for that follow-up. And we're at time. So just to wrap things up, I know that we're in a moment nationally where there's a lot happening. It's an emotional time. You all have shared some really emotional and personal stories. I'm wondering if we can end on a motivational note, and if each of you could just share what keeps you going. Senator, I know you already touched on that in your last comments, but if you have anything to add, and I'd love to also hear from Dr. Henry and Councilman Oriadha, what keeps you going?
Our students and future practitioners, I do believe wholeheartedly that our future is in the hands of our students and the people that we train. And the reality is we have to make these conversations known. It's sad that it's the first time a medical student would be hearing about something like this. You're like, what are you talking about? Everybody has bias. But it keeps me going because they want to know about it. They want to address their biases. They want to be aware, and they want to move forward. Believe it or not, they don't want people to die, and they definitely don't want Black women to die. But I think having these discussions have put them on notice so that they are acutely aware. So it keeps me going to know that if I can teach beyond the statistics and liken Black women to humans that should be treated equally, that there is hope, and there is hope in our future students and practitioners. Thank you.
I would say probably two things keep me motivated and going. I live by this quote: greatness is not a measure of who you are, but the impact you have on others. And so you'll see I have a Shirley Chisholm poster behind me. And so it is like every single person that has come before me to allow me to have the opportunity and the freedoms and the space to be in rooms that impact change. And then secondly, as of, I guess, 5 months ago, my son, I think it has re-centered everything for me. And I think what motivates me is that I just really want to leave it better for him. And I want to make him proud in who I am and what the history books say about me.
And I think for me, it is the young people. They're so inclusive and wanting to make a difference and wanting to make the world better. And so that gives me hope. It also is women who are in not just office, but also in positions of power and influence. And to see them using their influence unapologetically to help save the lives of Black women, to respect the lives of Black women and Black mothers. Those are the things that, in addition, are motivating to me to just keep going, because it can get difficult. But you look around and you see the next generation and you see all these wonderful women doing great things, and it can't help but just motivate you.
Well, thank you all so much for being the fearless leaders, taking us into the next generations and leading those who will come after to hopefully a better experience when it comes to birthing and a healthier community. I thank you all so much for not only being here, but sharing a bit of your stories and all of your brainy thoughts about how we can do better and what we can do moving forward. We are so grateful to you. I know we have a lot to unpack, so this is the official end of our webinar, but we will have an open discussion session that all attendees are open to stay on the line and have a discussion. We'll allow you to come off of mute and talk with each other. Unfortunately, our panelists are busy people. They got to go. I will let you get on your way. But thank you so much for being here. And so, as I referenced just administratively, if you are interested in participating in that discussion session, just stay on the line and we will move into a few discussion questions and unpack everything we heard together. I just have a few notes to close. We have an evaluation immediately following this webinar today. Please take just a moment to answer those few questions. We also are going to do a 3 to 6 month follow-up survey. We'd love to hear your thoughts on, after some time has passed, how you've used this information and how it has impacted the work that you do. And I think with that, I already saw in the chat, we answered the questions about distributing slides and distributing the links. So we will certainly do that. And one final note, this webinar is part of an ongoing series called the Equity Equation that we discussed a little bit earlier in the presentation. We'll be having our next session in the late summer, so please stay tuned for more information on that, and we hope you can join us. And in the meantime, you can find this information posted on our website. So with that, I think we're gonna move into our discussion. I will turn it back over to Tetua. And because this is an open discussion, we wanted to stop the recording at this point so people can feel free to discuss and have a great conversation.